Say it again? Yes. With osteoarthritis, yes. With rheumatoid arthritis, maybe. It all depends on what's being irritated. It depends on what the level of perceived pain is. With now we don't have any clinical literature that's been published on either of the two, but we know that if you increase bone density and you increase the density of tendons and ligaments, if there's bone that is in contact with other bone, let's say cartilage is going down and there's pain in the joint, if you build the supporting tendinous and ligamentous structure around the joint, there could be less contact inside the joint, which would cut pain significantly. Now, if cartilage is damaged, that's kind of permanent change. We're not going to recover that with this therapy. But what we can do is lessen the contact and strengthen the supporting structure around it. Also, the muscular tissue becomes stronger around that joint. So it's a different type of muscular stimulus. It's not like weightlifting, but as you saw with the woman who applied 10 times her body weight to her lower extremities, she's creating that force. So if she's creating 10 times her body weight with a voluntary action, of course there's tremendous muscular stimulus. However, it's not muscle like you think about gym muscle or fitness training type muscular development. It's a stimulus of density. So you asked a very technical question. You're going to get the technical answer. So when you exercise, let's say you're lifting weights, or you're doing push-ups or squats or something like that, you're going to do it until you fatigue. The fatigue has to do with running out of energy, right? You get tired, you can't do it anymore. So there's 3 fuel systems within a muscle. There's adenosine triphosphate, or ATP. You probably remember that from biology class. Joe, you remember that? ATP, glycogen, and creatine phosphate. You don't need to remember those, but there's 3 fuel systems. And you run out of them in that order. And when you're out of everything, that's when you're exhausted. You know, you're doing squats and you collapse. I can't do it. Can't do it anymore. We know what that feels like. So you ran out of fuel, therefore your body adapts by replacing those fuels and potentially puts a little bit more fuel in that cell so you can sustain more contractions. Biodensity doesn't do any of that. What it does is takes the muscle to fatigue, not from a fuel standpoint, but from a structural standpoint. Same as bone, same as tendons and ligaments. So because you're voluntarily putting force on the body that challenges the structure of all 4 of those tissues, every adaptation is specific to the imposed demand. So the specific adaptation to a structural deficit is a structural change. So what you have is a density, a creation of more density within the muscle cell. So you get actin and myosin merging to become another myofibril. You don't remember that either. Basically, the muscle becomes more dense. The muscle becomes stronger without getting any longer. So stronger, harder muscle, not big muscle. And there's all kinds of implications with that. Postural changes. I'm in the process of writing another book that specifically talks about other things seen with the use of osteogenetic loading. And posture is going to be discussed in that. And I think I shared some pre and post x-rays with you, didn't I?
Well, what I remember is the diabetes thing. I know you can't talk much, but...
Right. I can't go into specifics about type 2 diabetes because it's preliminary, and what we've seen anecdotally, meaning just patients who have type 2 diabetes or have had pre-diabetics. They've noticed that they took a blood test, they're pre-diabetic. 6 months after starting biodensity, they visit their doctor and says, "You're no longer pre-diabetic, I don't know what you're doing." But generally it doesn't go in that direction. Pre-diabetics typically become diabetics. So now we're talking only about type 2. Type 1 and type 2 are very different diseases. So when we began to see this, it made perfect sense with some of the discussion that we were just talking about. When you increase the density of the muscle cell, you have new insulin receptors within the cell. So somebody who has a glucose management problem is going to be able to address that problem to an either small or large degree, depending on how they engage in therapy or how well they can engage in therapy, because they're changing that dynamic of how muscle tissue can manage that energy for the reasons that we're talking about. And that research is going to be starting in the next few months in China with a huge sample size. Very exciting. Yes?
Do you recommend this?
I recommend you discuss it with your physician and have your physician review the clinical literature. So there have been patients that have seen great results with spinal stenosis, but you always consult your physician before.
Okay, that brings up another question. So who cannot use this machine?
There are only two contraindications. One is muscular dystrophy. Anything that involves protein synthesis with muscular dystrophy can actually accelerate that condition. So nobody with muscular dystrophy. The other one is unmedicated hypertension. So somebody has high blood pressure, they haven't addressed it, done anything about it, they're not taking any medication, they should not use bioPower10 until they address that problem. Those are the only two contraindications. Now, any type of joint dysfunction, even joint replacements, you see very positive results, but always speak to your physician. And it's important, and share this with your friends and everybody you're going to be talking to in the area who are going to come in and use the device. It's important to talk to your physician as opposed to just anybody or doing a web search or something like that, because your physician knows everything about you. This is why when you meet a doctor at a cocktail party, they won't give you advice. They'll say you need to talk to your physician. Because there might be 10 things going on inside of you that your physician is familiar with, whereas the doctor you meet at a cocktail party might not know all those things. Therefore, they're just not going to give you any advice. So it's very important to talk to the person who's in control of all your medical records and all the background information. It's very important. Yes?
I have a couple questions. What if you have a bad knee, bad shoulder, bad hip? Would this not be a good doctor?
Again, consult your physician. However, when you engage in use of the device, you're going to place load through, when I say kinetic chain, I mean a multi-joint movement, so the joints work together, that's what it means. So, for example, if I'm squatting down, I'm bending at this joint, and my ankle joint, right? So all those joints are working together so that I can move my body downwards. When engaging in bioPower10, that would be the kinetic chain that would involve one of the vertical lift, the spinal also would involve. But you would engage to whatever degree you felt comfortable with, and you'd be able to determine whether that would aggravate the condition or not. Typically not, because a lot of joint dysfunctions are irritated by motion, whereas there's very little motion, there's compression. So your body is designed to be at its most powerful and strongest, where your reflexes would protect you from impact. Very important to keep in mind. So your body knows if you jump and land, you're going to have a 120-degree angle behind your knee. Pretty much doesn't matter your age, your level of condition. If Joe jumps up and down, or if my mother jumps up and down, they're going to land at the same angle behind their knee, because we all assume the same positions when absorbing, when protecting ourselves. So even a compromised joint is still going to be at its most powerful in those positions. So try it.
And then also, consulting physician first. Is there any research for people with bone cancer?
There is no research for people with bone cancer. Talk to the oncologist and share with the oncologist the clinical literature. You can get it from Mary.
Okay.
Yeah, it's important that there are many different ways that the physician may be, or a group of physicians may be approaching that health challenge. So we want to make sure that they're aware of what the patient may be. So very important to share that literature with them. And when they see the literature, osteogenic loading is pretty, how do I want to describe it? There's not many complications that could come from a natural process of treatment. However, they would know, and they would also know the health of the patient from multiple different